Broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining us, everyone. We will get started in just a minute.
Karen, I just put an update in the chat. I think we're good.
Okay, well, perfect. Thank you for that. All right, well, welcome everyone. Thank you so much for joining us today. My name is Karen Cordero. I am the Director of Education and Support with the Adult Family Home Council. So today we are going to have several sessions, training sessions about this new program that's coming out through the managed care organizations and the Healthcare Authority. And so these programs you might be familiar with or have residents who were receiving care, behavioral health, personal care. Sometimes they're called MCO in ETRs or MCO personal care. Or you might have had a direct contract or a single case agreement in lieu of service contract with an MCO and being paid directly by an MCO in the past. Both of these types of programs are going to be transitioning into two new programs. One is called Community Behavioral Health Support Services, and the other is Intensive Behavioral Support Services or Supervision. And so today we are going to be going through the process you're going to need to follow in order to get paid for providing these services. And so the first session here, this first one is 1 hour, and this is an intro to the supportive supervision or the CBHS and IVSS services. And it's like I said, it's 1 hour. We will cut it at 55 minutes, so we have 5 minutes to transition into the second hour, which will be all about completing that core provider agreement. Then the third hour is specifically about contracting with MCOs. So each of these sessions are going to be worth 1 CEU, and those certificates will be emailed to you to the email address used to register for this webinar. And you just want to stay online for the entire presentation. And I think that's all the housekeeping I have. With that said, I'm going to go ahead and turn it on over to Courtney, and she's going to get us started.
Thank you, Karen. Good afternoon, everybody. My name is Courtney Ward. I'm a manager with Community Health Plan of Washington. If we want to just go to the next slide, Nicole, that'd be great. Community Health Plan of Washington is one of the 5 managed care organizations in Washington State that you will be working with for both these new benefits. And we as a collective group will be walking you through the content that you see on the slide today. So you'll get a brief intro from each of the managed care plans, and then we're really going to dive into, what is happening or has already happened for these new benefits that happen with adult family homes, assisted living facilities. We'll also talk between the two benefits and how they may differ in the referral and documentation requirement and other areas as well. So we could go into the tribal welcome. So we like to kick off each meeting training with a tribal land acknowledgement. As we gathered virtually from various locations across the state of Washington, we humbly acknowledge that we are all meeting on the traditional territories of hundreds of indigenous tribes. As managed care organizations, we are committed to upholding tribal sovereignty through our dedication to addressing health disparities amongst American Indian, Alaska Native communities caused by historical systemic racism. You can learn more about the tribal lands that you occupy at the website provided here, or you can text to this number and enter your zip code to find out more as well. We will be sending this deck out after this presentation, so you will have this as a resource guide. But we will move this along and get into the introductions by each managed care organization. And I believe, yes, I will kick it over to my colleague, Carmen, from Community Health Plan of Washington.
Thank you, Courtney. Good afternoon, everyone. I'm Carmen Ballman, a member of the Provider Relations team for Community Health Plan of Washington. I'm glad to be with you today to share some information about CHPW. Community Health Plan of Washington is a nonprofit organization and a local plan. Since 1992, we have served enrollees, communities, providers, and community-based partners in the state of Washington. CHPW service in Washington state alone has helped our plan to have a greater understanding of our regional cultures and resources. We believe it's a great advantage that CHPW staff lives and works in the same communities as our members, and that our executive leadership are also local. CHPW administers 3 health plans: Apple Health, serving in all counties in Washington state; Medicare Advantage plans, including the dual eligible plans in 27 counties; and also Cascade Select, the largest service area for a public option. CHPW strives to make continuous improvements to help with patient outcomes by adding alternative treatments as a benefit for our members. CHPW is well known for our flexibility and responsive approach. We have dedicated staff that work each day to meet high customer service standards for our members, our providers, and our community-based partners. Thank you, and we hope you found this information helpful and enjoyed today's presentation.
Hello, I'm Laurel Schilling. I am one of the directors of behavioral health with Coordinated Care of Washington. I also oversee some of the special programs that we coordinate with for our Medicaid members. And that would include our CLIP program, the WISE program, as well as this new waiver service that you guys will be learning more about today. Coordinate Care is one of the managed care organizations. We offer no-cost and low-cost health insurance plans to individuals and families all across Washington state. We have over 400 staff that live and work in every region across this beautiful state. And we serve over 300,000 members statewide. Coordinated Care launched in Washington in 2012, and over the past 10 plus years, the number of members that we serve have grown from 34,000 to over 300,000. And I will kick it over to my colleague at Molina.
Hello, good afternoon, everyone. I'm Becca Gregory, joining you today representing Molina Healthcare. Molina's been serving enrollees in Washington for quite some time, for over 21 years, and we are the largest managed care organization in Washington, having over 900,000 members all across the state. We've been providing integrated managed care since it began in the state in 2016, and now we do so in every region of the state, serving both Medicaid and Medicare members. We're really proud of the quality that we provide to our members, being an NCQA 3.5 star rated Medicaid health plan. And we're really honored to be #1 in client choice, meaning that when members make a choice on who they want their MCO to be, they choose Molina 50% of the time. We're also consistently rated #1 in provider satisfaction, so we really look forward to working more closely with you as we implement these benefits.
Hi, everyone. I'm Nikki Jones. I'm the Behavioral Health Clinical Director for the Washington Medicaid program, and I appreciate you all coming here today. United Healthcare serves a significant portion of the Washington Medicaid population, with over 300,000 members currently enrolled under our plan, which makes UHC the second largest Medicaid provider and the largest D-SNP insurer in Washington, with nearly 70,000 members served. While our primary mission is seeing our members live their happiest, healthiest lives, our staff are also working to improve the overall population health of the communities where we live and work through our relationships with community partners, public service events, and the development of resources which are available to individuals with or without insurance coverage. As we work through the process of onboarding, I want to encourage you to reach out to our team with any questions or concerns you may have regarding the contracting process. And thank you. Next slide.
Good afternoon. My name is Chris Kumnick. I am a Senior Director representing WellPoint today. WellPoint is one of two integrated managed care organizations that are statewide. We serve over 250,000 members on a day-to-day basis and are contracted with over 65,000 providers. We are NCQA distinct organization and have achieved over 80% value-based purchasing arrangements. We have a strong focus on partnering collaboratively with our providers, looking to engage and support all of our providers through this transition. Thank you.
All right, and this is Nikki again with UHC. We're going to give you an overview of what supportive supervision is and how it will look. So originally, the intent of supportive supervision is to provide direct intervention for those members in your care who may require additional one-to-one support for their behavioral health condition, in an effort to prevent that individual from harming themselves or others. To identify an individual who is appropriate for supportive supervision, key areas to consider are their willingness to engage in services voluntarily. An individual cannot be pressured into accepting these services, nor is it appropriate to refer an individual who is declining the additional support being offered. And the second area you will want to look for is ensuring the behavior for which supportive supervision that is being requested originates from a primary behavioral health condition. So when appropriate, supportive supervision is offered in conjunction with other services such as behavioral support or crisis plans. The goal of supportive supervision is to help the individual build their skills and resiliency to help them remain in the community as recovery is possible for individuals with behavioral health conditions. Next slide, please. And this slide is owned by HCA, is my understanding.
Yeah, I believe someone from Home and Community Services was going to speak to this slide.
Sarah, are you there?
Yes, are you able to hear me?
Yes.
Okay, good. Thank you. Okay, so the current state is that the MCO funded behavioral health personal care, so authorization SA 389U1 is approved by the managed care organizations, but is authorized by Home and Community Services. So residential providers claim for personal care and behavioral health personal care services code SA 389 through provider 1. But in the future state, after 7/1/24, with the implementation of CBHS, Home and Community Services will continue to authorize personal care and providers will continue to claim personal care through provider 1. That will not change. But the authorization for CBHS will be through the managed care organization or healthcare authority, and the provider will need to claim directly to the MCO or HCA for supportive supervision. CBHS does not replace personal care. CBHS will be priority program for the one-on-one staffing support. Providers can continue to reach out to their assigned HCS case manager for questions related to HCS authorized services, including but not limited to RSW.
All right, and now we're looking at ways to provide supportive supervision. Starting in January of this year, individuals have been able to access supportive supervision services through intensive behavioral support supervision, which formerly was called in lieu of services. And beginning July 1st, 2024, the ability of individuals to obtain supportive services will be expanded to those individuals who are recipients of community behavioral health support services. Next slide, please. As you can see on the slide, the provider types for supportive supervision align with those for community behavioral health support services, including those providers in adult and enhanced adult residential care facilities, enhanced service facilities, and adult family homes. Next slide, please. Behavioral health personal care evolved into community behavioral health support services through legislative efforts designed to create a covered Medicaid benefit under our Medicaid state plan. What some of you may not realize is behavioral health personal care was paid out of the general fund, which is non-Medicaid funding. There were and are multiple programs, not just BHPC, which were paid out of the general fund, resulting in this funding source being overspent every year. This posed the risk that BHPC funding requests would be denied due to a lack of financial resource. Fortunately, as BHPC transitions into CBHS funding on July 1st, these services become a Medicaid-covered benefit, and the risk of these services being denied due to a lack of financial support is now eliminated. Next slide, please. Intensive behavioral supportive supervision is an in lieu of service. In lieu of services are an opportunity for an individual to be transitioned from a hospital or institutional setting to a community residential setting. If appropriate, services can be put into place to help that individual be successful in the community setting. Like supportive services, in lieu of services are voluntary, where the individual must voluntarily consent to receive in lieu of services. Each MCO will review the in lieu of request to determine if the proposed in lieu of service plan meets criteria for approval as a medically appropriate and a cost-effective alternative to an MCO contracted state plan covered service. Next slide, please. At the beginning of 2024, the Centers for Medicare and Medicaid Services changed the requirement for approval of in lieu of services. And CMS requires their approval over each service offered, and the service itself must be designed for the target population. To create more options, the Healthcare Authority developed intensive behavioral supportive supervision as a form of in lieu of service, designed to reflect the definition of CBHS. However, intensive behavioral supportive supervision is available to a different population than those covered under CBHS. If you would like additional information on IBSS, you can select the link for the Healthcare Authority's policy guide when you receive this slide deck or complete an internet search for Washington Health related social needs policy guide for further information. Next slide, please. There are notable differences between ILOS, Intensive Behavioral Supportive Supervision, and CBHS, Supportive Supervision. There are distinct authorization periods, with CBHS renewals occurring at the 1-year mark, whereas an ILOS authorization period is not set at a specific authorization timeframe, but cannot exceed 12 months. Only CBHS requires an individual to meet LTSS eligibility, and CBHS offers more flexibility in serving both managed care enrollees and Medicaid enrollees without a managed care plan. Where ILOS as a service is only accessible to managed care enrollees. Managed care enrollees include those with traditional Apple Health, Medicaid coverage, those who are fee-for-service or behavioral health services only, and those who are enrolled in IFC, which is our state's foster care program. ILOS offers coverage for individuals with severe cognitive impairment. This includes individuals diagnosed with intellectual disability disorder, while CBHS is specific to individuals with mental health diagnoses and one TBI code that is included in the authorization list. Now, the Molina representative will provide an overview of the eligibility criteria for the CBHS program.
Thank you. This is Becca again with Molina Healthcare. So to meet criteria for supportive supervision under CBHS, individuals must meet both financial and functional criteria. Both of those are confirmed by the healthcare authority, and they're authorized for no more than 1 year at a time before there would need to be a renewal of eligibility. This is a benefit for people who are 18 years of age or older and who are eligible for Apple Health Medicaid in Washington State. A person must also be functionally eligible for long-term care services as assessed by Home and Community Services, meaning that they have a need for hands-on assistance with one activity of daily living or supervision with 3 or more of the qualifying ADLs. One important call out here is that only HCS clients are eligible for CBHS. Individuals who qualify for long-term care through the Developmental Disabilities Administration or DDA don't qualify for CBHS. And they must currently reside or plan to reside in one of the qualifying community residential settings: adult family home, assisted living facility, enhanced services facilities. And the next two components of eligibility are that an individual must have a qualifying diagnosis. You can go ahead and change slides. And meet a specific set of risk criteria. So we'll address these diagnoses first. There's quite a lot of mental health diagnoses that will qualify somebody for CBHS, assuming that the risky behavior that requires additional support is also related to that diagnosis. So you can review a sampling of those qualifying diagnoses on this slide. And if you're interested, the full list is in the WAC that's also referenced here. And one thing to note is that unlike in behavioral health personal care, there is now one diagnosis code for traumatic brain injury that is included. Okay, move on to the risk factors. People receiving CBHS must have current or recent being defined here as within the last year, current or recent behaviors that can be directly linked to their qualifying mental health diagnosis and that have a significant impact on safety, whether that's of the individual themselves, perhaps other residents, staff, etc. There are 5 main categories that these qualifying behaviors can fall under. First one being multiple assaultive incidents that occur while receiving inpatient treatment or in a long-term care setting. Self-endangering behaviors, intrusive behavior that could put the individual at risk of being assaulted, chronic psychiatric symptoms that both cause distress and escalate the individual or their peers to crisis, meaning that symptoms like delusions and hallucinations would need to have a consequence of causing harm or escalating to crisis, or the potential to, in order to be considered an eligible risk factor. And the last one is sexual inappropriateness. And now there are 6 items listed under this umbrella of the first eligibility risk factor. The last one is meant to capture the fact that sometimes people have a history of these behaviors that's more remote than the last year. But because now they're in a structured setting and they're having consistent support and interventions from staff, they're quite stable. And so individuals who fall into that category will also be able to meet this risk criteria. Lastly, as far as risk criteria is concerned, individuals need to meet one of the risk factors in either of these 2 categories. So not both one under number 2 and one under number 3, but one in number 2 or 3. The first category is a history of being unsuccessful in other community living settings. This individual could have multiple unsuccessful stays in residential settings and or have frequent caregiver turnover due to their behavioral needs, all within the past 2 years. Or the person could not have that history but be in danger of losing their current residential setting due to their behaviors. And the second category, number 3, is history of psychiatric treatment where someone's been unable to significantly improve without services like supportive supervision. The look back period here for this risk criteria is 12 months, and it would include having 2 or more inpatient psychiatric hospitalizations, having an inpatient stay related to mental health that is a long length of stay, 30 days or more, and or discharging from a state hospital or a state-funded long-term civil commitment bed, all within that 12-month time frame. There's also allowance under number 2 and number 3 here for people who are stable because of the current support that they're receiving. And if that support were to be removed, they might be at risk of losing their current setting, or they might be at risk of rehospitalization. The eligibility criteria for IBSS are similar. The most notable differences are the qualifying diagnoses and that the individual could be receiving long-term care through DDA or HCS. So still need to be an adult 18 years of age or older, enrolled in Apple Health, or eligible for Apple Health, and to have a diagnosis that falls into the category of traumatic brain injury, intellectual or developmental disability like autism spectrum disorder, dementia, other neurocognitive challenges, or substance use disorder that has led to significant cognitive challenges over the long term. And just like with CBHS, these complex behaviors need to be related to the qualifying diagnoses and present a risk of harm to self or others without additional support. The same settings apply as far as adult family home, assisted living facility, or enhanced services facility. And we would want to make sure that if an individual did have a diagnosis, a co-occurring diagnosis maybe of mental illness, that we rule out CBHS eligibility first. So if they're enrolled in home and community services and they have a diagnosis of mental illness, we'd want to first do the CBHS process and then go to IBSS if they don't qualify. And we'll hand it over for an overview of the referral and authorization process.
Thanks, Becca. So this is Chris. I'm going to walk through the referral process. So once you identify if you believe an individual may be eligible, similar to the eligibility areas, there are 2 different referral processes for CBHS and in lieu of service IBSS. So first for the CBHS, the eligibility is really connected to the completion of the care assessment process. So if you feel that an individual may benefit from CBHS, you can contact the HCS case manager. That case manager is then responsible for completing that referral form, the initial part, and submitting it to the HCA for fee-for-service or MCOs for individuals in managed care. A copy of what that referral form looks like is available on CBHS website in June. For in lieu of services, anybody can submit a referral to the MCO. It could be the hospital, the AAA, DSS, HS, provider. And providing the diagnosis and a description of what those behaviors are for that client that they're exhibiting is really helpful to get that referral started. Next slide, please. So for CBHS, it can take up to 10 business days to process that referral once it's received. There are multiple steps within the referral between the MCO and HCA to work through not only the approval of the referral, but also eligibility. And this timeline does include obtaining that authorization when the provider is known. So in situations in which we receive a CBHS referral where the provider is not known, this timeline could be longer. Next slide, please. For in lieu of services, the MCO will need an authorization request from an IBSS provider for the amount of that service requested. So although we talked about the referral can come from anybody, really the authorization request needs to come from that provider for the MCOs to start processing that authorization. It needs to have all clinical information included in that authorization request at the point, and that's really to assure that we have a timely determination. If there's clinical information that's missing, that does not allow us to have MCOs to be able to make a decision on that request that can extend the process. And once the authorization request is submitted with all that needed information, a determination can be made within 1 to 5 business days per your MCO contract. Next slide, please. Part of the referral review process is determining the right level of service to be authorized. So the services are really authorized through 6 different tiers, and they are specific to the hours that we're targeting of supervision on average during a day. And we say average because we really look at the total number of hours across the whole week, Sunday through Saturday, and we divide by 7, recognizing individual support needs maybe are fluid throughout the week. So through that process, we have a guidance document that allows the MCOs to review the information and make tier determinations. Next slide, please. So notice, so once we can go through the process, CBHS clients and notice their eligibility notification will come from HCA, and it will become a welcome letter. And this confirms the financial and functional eligibility. This notice will occur annually upon the member's renewal date. If a member is not eligible, a denial letter will come from HCA, and it will be called a Notice of Adverse Benefit Determination. For CBHS authorizations, individuals and providers will receive that authorization letter directly from the MCO. That authorization letter will include what level tier is being authorized and the length of that authorization. Authorization notices are also sent when there's a change in circumstance, which we'll touch on, and when there is a renewed authorization. Just want to note, for members that are transitioning from behavioral health personal care to CBHS, HCS will be the one sending the letter of notification to the client of those changes. Next slide, please. For IBSS authorizations, again, different than CBHS authorizations, when an authorization determination is made, the client and provider will receive the approval letter or denial letter from the MCO. Again, it will still be Notice of Adverse Benefit Determination, but those will all come from the MCO. The letter, similar to the other authorization, will include approved tier and the time period for that authorization. And notices are all sent. Notices will be sent if there is a change in that authorization, including a suspension or reduction, or if an authorization is terminated. Next slide, please. So how can providers request and that form is 130125. And within that request, that's looking for a new authorization and a change. That request for new authorization will go to the MCOs to reevaluate, and will receive notice of change in authorization if it the MCO if they are requesting a change in that service, either up or down. Next slide, please. So I want to touch on clinical documentation. You can move to the next slide. So in order to use Medicaid dollars, we need to verify that services are being provided. To do so, we're requesting providers to keep a log of services provided for each day. We've developed a supportive supervision tracker and attestation form to assist providers with that documentation. The form includes just basic client information, so name, date of birth, and has a place for date of service, hours provided, and a summary of those services. That form will need to be completed each day by the provider, and that log can also be used to help support renewals or changes in tier level. So it allows you to track what you're actually providing, and when you see those changes, it could justify the need for a request for a change. But that really allows and shows the level of service that's being provided, and it is your documentation for that if ever requested. Next slide, please. And I'm going for in lieu of service, IBSS, plan of care documents, adult family homes and assisted living facility providers are required to have preliminary care plan completed at the day of admission and a negotiated care plan within 30 days of admission. The IBSS providers will assure that these care plan documents include the key requirements in the HRSN policy guide that's out, which includes care specific to that individual's needs, your overall staffing plan, any crisis response plan that's in place, your readiness plan for staffing. So how will you actually make sure the staff are ready to provide that support, and a reevaluation plan specific to individuals that ensure that the appropriate level of support is in place for community stability. Next slide. And now I will pass it to Courtney.
Thank you, Chris, and everyone. That is the end of our presentation for this session. Again, we will send out this deck. This is a helpful resource page of the deck. So if you have questions regarding the CPA process or the serving the fee-for-service population for these two benefits, you can contact the HCA at this email address. Some other helpful resources are the links to some of the documents we went over today and that we will go over in session 3, that is later this afternoon. If you want to go to the next slide, and we have saved plenty of time for questions.
Yeah, thanks so much, Courtney. And actually, this is very strange, but I am not seeing any questions in the chat at this moment. So if somebody has some questions, feel free to type them into the chat feature here on the toolbar. Here's a question. When a negotiator is assigned, what is their purpose?
This is Courtney with Community Health Plan. I'm not sure I understand the question, so if somebody else does and wants to take this, please step in. But Alyssa, if you want to clarify that.
So while Alyssa's writing that in there, they want to know the names of each of the MCOs. And just to let you know, you will be receiving this whole presentation slide deck, and it will actually have the contact information for each of the MCOs with, of course, with their names. So I'm not sure if we want to answer that verbally or if that would suffice. So Jennifer, let me know if you want any more information than that. Another question, do residents that already live in assisted living who have mental health diagnosis qualify for this program?
Yeah, this is Courtney, and as Becca went over and it's listed in some of the slides, the mental health diagnoses alone will not qualify you for the program. But it is required for both IBSS and CBHS. The qualifying diagnosis is required for both those benefits.
Great, okay, thank you. So Jennifer had a clarifying question that she's missing the name of the person who presented for CHPW and coordinated care.
So there's a couple of people that presented for CHPW, myself, and my name is Courtney Ward, and then Carmen Ballman also presented our overview introductory slide. And then for CCW, that was Laurel Schilling.
Yeah, so Misty's asking for a clarification if it's mental health diagnosis plus behaviors.
And I'm going to defer to Becca or somebody from clinical if you want to elaborate on that one.
Yeah, so yes, both of those things are required to have a qualifying mental health diagnosis, as well as behaviors related to that diagnosis that have some consequence on safety. That would impact somebody, that resident safety, maybe other resident safety or staff safety, amongst some of the historical requirements as well. So do they have a history of receiving support, like through behavioral health personal care that we would take into account? Or do they have a history of significant hospitalizations or significant long-term care setting disruptions?
Thank you. So going on to this question here, the adult family home provider has a client on the daily rate and is going to be on a tiered program. It has been assigned a negotiator. What is the purpose of the negotiator?
Is
There's
that
another.
a,
Go ahead.
sorry, is that an MCO specific name for your provider outreach folks, perhaps, or your contracting team?
Becca, I think that I know our rate negotiations team handles single case agreements. So that could be who they're hearing from.
That seems to make sense. So that person then in that situation would be working with you to put into place a contract, or in that case, a single case agreement. So a contract specific to that client with the, so that services can continue. With CBHS, we are required to use that tier, those tiered rate, or I'm sorry, we are required to use that tiered guidance to identify the amount of services that that individual needs. I hope that helped.
And I see Emily wrote in that it says CCW negotiators will send the contract documents. So going back up, is the behavior form submitted every day, weekly, or monthly to the case manager?
This is Jessica Diaz at Healthcare Authority. I can take that one. There will not be a set time for you all to submit the form with your notes. That's really something we have to do on our end because of using the Medicaid dollars for this. And it's more about, well, there's two purposes. One, if there's ever any monitoring that we need to do based on our federal rules. Or two, if you are using it and noticing that you're having to do more intervention or redirection, you could use those forms when you're in conversations with the managed care plans to try to say, you know, here's what we're seeing and why there's an increase. So can you move us up a tier? Or I'm not saying that very eloquently, but you can use that as well to support asking for more services.
Good documentation on the amount of service that they're providing and would be essential for that. Is that right?
Yes, thank you.
Yeah, no problem. All right. So another question that actually we get this question quite a bit. If somebody is already receiving ECS or SBS services, would they also be able to potentially get these services?
So I'll take that one too. Yes, the short answer is yes. The caveat being that Medicaid is not, you're not able to use Medicaid funds at the same time as another service. So for example, the SBS, if you had your 6 to 8 hours, is my understanding, you would put your, you would submit your schedule. Then 1915I could, if you needed more than that time, it could wrap around that, and vice versa. But they can't be provided or billed simultaneously, if that makes sense.
Right, it has to be for services in addition to what you're already providing through ECS and SBS. Is that correct?
Yes, it would be, either way, you would wrap around the other one, yes.
Got it, yeah. Okay, thanks. All right, another question. If the resident is already qualified for this program, does it continue or will there be a change?
So I believe the answer, I'm trying to find the question just to reread it. So yes, every client, the criteria for the current BHPC and the criteria for the 1915I, using other acronyms, the CBHS services, is slightly different. And so they will, all of them will, as their care assessment comes time to redo it for the year, that a new referral will be triggered and they'll transition from BHPC to the CBHS services.
And I just
And
want
at
to
that
caveat
time,
that they will transition if they meet the criteria for CBHS.
yes, thank you.
Okay. If the resident has bipolar disorder and schizophrenia, but are not stable on any medications and they scream and yell at others and the staff, or other clients and the staff, and they need intervention every day to distract them from this behavior, would that person potentially qualify?
I would say potentially, and I would suggest you reaching out to your case manager to help with kind of going over things and getting a referral sent to the healthcare authority.
Okay. So what if an adult family home has several residents on different plans? Will they have different forms to fill out based on each client's plan?
So there's a couple different things if you are serving clients on multiple, with multiple MCOs. The first would be contracting with multiple MCOs. So in that regards, the MCOs have done a lot of work to have all of their information and what they're requesting and everything in their contract template streamlined as much as possible. So you would have to fill it out and submit it to the applicable MCO, but it's a lot of the same information. The same with the client form is the same regardless of an MCO. Trying to think what other forms, that all MCOs will be using the same tiering guidance. MCOs, if you have other examples, feel free.
Yeah, the template that will be used for billing is also the same, but will need to be kept for separate MCOs and submitted separately.
Thank you, good call out. And we'll talk more about that in session 3.
Great. Do all staff who work in the adult family home have to take any special training or this training in order to care for residents with behavior issues?
There is not a specific training at this point in time for folks to be able to provide this service.
So another question. So we have monitoring forms for ADLs and behaviors and activities we use for daily documenting already. Can this be in lieu of your forms that were developed?
I think that's a great question, and I'd be happy to, I think I would need to see the forms to be able to answer that. We want to make this as easy as possible, but right now we're having it try to be a streamlined form. We could look into if there's alternatives. That I would also say it would have to still document the one-on-one, what hours you provided and sort of what services that one-on-one staff was providing to that individual.
Okay, good, thanks. It is my understanding that adult family home providers will be making 3 different billings, one for the healthcare authority for personal care and another one for the MCO. Is this correct? And who shall we be sending our ECS and SBS bills to? Can you please clarify?
So personal care and the codes you're using and the way that you're billing for ECS and SBS will not change. You will continue to use the same processes. The difference will be right now, HCS currently authorizes the payment for BHPC and then pays you, and then on the back end does some stuff. And now that portion will go and have to be billed directly to the MCO.
Is the payment based on hours spent with the resident, or is it a flat rate per day?
It is based on the hours with the resident, and there are 6 tiers that we incrementally increase the hours, you know, from 0 up to 24. And so if the person needs just minimal 1-2 hours a day, they would be in tier 1. If they need all the way, you know, progressively all the way up to tier 6, if they need 20 to 24 hours per day. So it's a day rate, but it's dependent on the amount of services provided.
Do residents receiving meaningful day services for behaviors qualify for this program?
They would if they met the eligibility criteria where they have the mental health diagnosis, they have the history, you know, those kind of 3 pieces. I'm not sure I know exactly the meaningful day criteria, so I wouldn't, it's possible, but I don't want to say yes for certain.
Right, and I think, yeah, I think you answered it, so it's perfect. Who will providers, adult family homes, etc., contact at HCA for any questions for their non-MCO clients? Will adult family home providers bill through provider 1 for these fee-for-service clients, or as they do currently for other authorized services, such as their daily rate through ALTSA and DDA? And I think you already answered that, but if you want to.
So that one will be a little bit different. If you're an adult family home provider, you will use the same spreadsheet that you will be using for the managed care plans, and then we'll pay you that way. If you're an assisted living facility or ESF, there are other ways in which you can directly bill into P1, but our agreement right now for adult family homes is a spreadsheet billing process.
Great, thank you. And yeah, you'll definitely learn more about that in the 3rd session today. So this next question is more about eligibility. So if a client's behaviors change and they become aggressive, if that client has a roommate, but being alone in a single room would be fine. With the presence of a roommate, the client may become aggressive towards others. Would she be qualified?
So the eligibility criteria that we've reviewed applies, with the caveat that neither CBHS or IBSS can be used for room and board, and it can't be used for personal care. So they would need to meet criteria aside from any justification about it being related to a private room.
Okay, good point. Thank you.
And also I'd say, sorry to jump in, I'd also say if you guys have questions about specific clients, it would be okay to reach out to the case managers and see if it would be appropriate to do a referral. And that would be for clients who aren't already receiving BHPC. If your clients are already receiving BHPC, we'll do that referral process at the care reassessment date.
Great. How do you differentiate the hours for SBS and those for CBHS and IBSS?
So IBSS would be generally, I think, different criteria than SBS allows, sort of generally speaking. We will need to work on each individual client to try to figure out how it'll work and how are we going to meet their needs. So, for example, if you had SBS and you said, I'm going to have somebody on my work schedule 6 a.m. to whatever 6 to 8 hours later is, and then the next hour I'm going to have 1915I from that hour to X hour later in the day. That would be sort of how we would try to distinguish it, but I think it'll be really dependent on each client's needs.
Okay, thank you. And I know a couple more questions just came in, but I realized or saw the time. And we actually do need a couple minutes to transition into the next session, which is going to be all about the core provider agreement and how to complete that. So thank you all so much for your great questions. I will definitely share that with our, the team at HCA and the MCOs. If you want to come and join us for the next session, that would be wonderful. And thanks to all the presenters as well. So I'll sign off now and meet you at the next session. Thank you, everyone.
Thank you.